analytics to avoid invasive and high-cost surgeries. My name is Sean Forster, and I will be the moderator for today's discussion. During the presentation, all participants will be in listen-only mode. We encourage you to ask questions during today's presentation. Please submit your questions using the questions window located on the right side of your screen. Type your question into the box, click send, and they will be sent directly to the meeting organizer to queue for the end of today's presentation. Should you encounter any technical difficulties during the webinar, please also utilize the questions window to describe your issue, and one of our support staff will follow up with you to troubleshoot. With that, we invite you to sit back, relax, and enjoy today's presentation. Our first speaker today will be Dr. Kevin Keck. Dr. Keck is the Chief Medical Officer for CO Health Analytics with over 25 years experience. At CO, he leads our clinical analytics development team, and his responsibilities include assessing leakage and the impact of quality and cost in provider analytics, guiding the use of prescriptive analytics to measure the impact of therapeutic classes levels, and enhancing CO's behavior economics model. Prior to joining CO, Kevin worked as a palliative physician at the Providence Health Plan. He led the effort to create value-based benefit design. Dr. Keck also served as the Chief of Medicine at Kaiser Permanente. Our second speaker today is Teresa or T. Ruger. T is an RN with a master's degree in nursing. She has a diverse background in healthcare, including healthcare technology solution support, care management, population health and analytics, education, managed care, medical compliance, and network management. Prior to joining CO, T spent the last 13 years at McKesson, where in her role as solution consultant, she provided support for software solutions for population health and analytics, care management, and decision support criteria. Prior to that role, she was an education specialist helping clients gain optimal value from licensed healthcare software. Her background includes working with clients in various areas of the healthcare spectrum, including health plans, health systems, and medical groups and providers. To make sure we achieve all of our learning objectives, we've structured today's presentation to start with Dr. Keck providing a brief overview of two key challenges facing the U.S. healthcare system and how analytics have evolved to meet this need. Dr. Keck will also introduce the unique opportunity to reduce costly and invasive surgeries presented by preference-sensitive conditions. He will then join our discussion to give us a deeper dive on how organizations can use CO's preference-sensitive treatment model to lower costs while improving care delivery. We will conclude the content portion of today's webinar by pulling back to show how the PST model fits within the breadth of CO's analytics capabilities. With that, I'll step aside and turn it over to Kevin and team. Dr. Keck?
Hello. Thank you, Sean. And then the one after this. What we're going to talk about here is the use of analytics to meet the challenges today facing U.S. healthcare. And the current system, we all agree, is not working. And CMS is leading a payment reform process that looks like this, that payers and providers are aligned on the move toward value-based care. 90% of payers and 81% of hospitals now offer a mix of fee-for-service and other reimbursement models. By 2020, it is anticipated that 2/3 of payments will be based on complex reimbursement models like capitation with underlying value measures. And Sylvia Burwell did this move earlier this year, that our target is to have 30% of Medicare payments tied to quality or value through alternative payment models by the end of 2016 and 50% by the end of 2018. Now, if you think about the Affordable Care Act, the accomplishment of making available health care for all using our current system. What it did not do was to manage quality and cost in an effective way. So what's going on here is the correct direction of pay for value as opposed to pay for service. In Maryland, what they have done starting in beginning of 2014 is pay the Maryland hospitals on a blended rate. They got the commercial payers and the and Medicare, Medicaid to say we're going to pay on a standard rate, and the outcome of 2014 is in. And what they did was to look at this IHI triple aim of what can we do to manage per capita cost, and what can we do to manage population health. And they found that they were effective in managing per capita cost, and their adverse events diminished substantially. They didn't do that well on experience of care, but this is being noted by CMS. So the point is the move to pay for outcome has a very effective national or statewide example now that CMS can point to, amongst others. Now, the triple aim is out as a result of the quality movement trying to bridge the chasm of quality, which is a result of our current payment system. And just as an aside, I was chief medical officer of a 300,000 life health plan in Oregon. And it was losing money. My system was going to sell it. So I was asked to take a crack at what do you do to make this thing work. And we did this. We looked at population health. We looked at patient experience. We focused on quality. And we succeeded. The outcome was that we had so much margin, the state of Oregon called us down to Salem and said, what are you guys doing? Because you're making too much money. So we explained to them all the quality measures in population health that we were doing, and getting our members seen, making the care timely, effective, patient-centered. And then the state of Oregon said, okay. And then the next year, they gave my health plan the state of Oregon school teacher group, and then the year after that, they gave my health plan the state employee group. So working towards the triple aim will have these results. The need to create systems of care is critical in achieving the triple aim. Doing current care patterns better will not get you there. And systems of care look like these, that one can create concurrent review in the hospital, for example. Prior authorization is done. Capitation, outreach, disease management, physician feedback, incentives, patient education, incentives, benefit design, how you contract with your network. Those are called systems of care, and we like to think there's 9 systems of care that it all fits into. So some of these are inexpensive, some of them are not, and the use of analytics will help in choosing which systems of care to create. Now, the standardizing care example in the corner on the bottom shows care variation amongst health systems, and you can see, and there's 3 systems, west to east, and they have varying length of stay with a total knee replacement, and that length of stay almost an 80% difference, or 180% difference. Operating room time almost double, or more than double. Complication rates 5-fold. readmissions over twofold. And when one looks at this as a chief medical officer or the chief financial officer of an entity, you say, what is going on here? Some systems are getting these surgeries done in an hour. Some systems take 2 hours. What are they doing? So this is an example of how variation is out there. And when one looks at this, one should see an opportunity of how can we do this better? Why is it that the readmission rates are so much higher in one system as opposed to another? So in looking at managing a population going forward, pay for outcome, another variable here is increasingly complex patient populations. So these are examples of burden of illness with seniors. And the upper left chart shows percentage of seniors who are obese back in about 1990 compared to 5 years ago. And in looking at this, one can see that obesity is increasing. Now, obesity is a major driver of diabetes, and we'll talk about that in a second. And diabetes is a major driver of hospitalizations, complications, healthcare costs. In the bottom chart, it looks at seniors with 2 or more chronic conditions. And chronic conditions can include diabetes or hypertension or heart failure or COPD or rheumatoid arthritis or seizure disorder. There's a group of about 20 conditions that comprise most of the chronic conditions that we deal with as healthcare providers. But you can see that the number of seniors with 2 or more chronic conditions is rising. That makes it more complex. And let me say here that what we tend to see in the senior population also obtains, but to a lesser degree, in the commercial population. And the commercial populations, as far as how we handle them as providers, tends to be the same or follow similar principles as the senior population. Now, the upper right graph shows rates of chronic conditions among Medicare patients, again, a decade ago, but it shows how these are increasing. And the graphs or the graphs show diabetes, depression, rheumatoid arthritis, and chronic kidney disease. And take a look at the top blue line, and that's the diabetes prevalence amongst seniors. And this is 2009. The latest is 28%. And you know, as an end-of-life or palliative care doctor, I attended about 8,000 patients in my time doing that. And one thing that struck me as I was seeing these patients who were very sick, they are having a life expectancy of about a half year or less, and they are frequenters of the healthcare system. They're in the ER, they're in the hospital, they go home, they get readmitted. What I noticed is everybody had diabetes, and it was almost a given that if I was asked to consult on a patient, they would have diabetes. And the reason for that is a high blood sugar tends to injure every part of the body, particularly eyes, kidneys, brain, heart, etc. So we have a problem. The next slide, when it comes up, you'll see that the number of chronic conditions that a member has correlates cleanly with the number of dollars spent yearly for that member. And as we see, the conditions are increasing in number, and the cost is also increasing in number. So what is the pathway to take to get to a better healthcare system? And we understand that it focuses on the depth of the analytics that you have and leadership to make the changes. So what we've got on the left side is what we have now, the fee-for-service reimbursement. Patient gets sick, they go to the hospital, then they're discharged, then they get sick again. If they go in and out and in and out, the focus tends to be on acute care, and the episodes of care are fragmented, that the rheumatologist doesn't know what the PCP is doing, etc. Analytics are the bridge to get to fee for value, well care, that the care is coordinated across the continuum, and the pieces are put together. When I looked at that bridge, by the way, in that slide, it reminded me of Radiator Springs in California Adventure at Disneyland, because there's a bridge representing Highway 1 that looks exactly like that. So analytics have evolved, and where I was back when I was managing my health plan was over on the left side, just some descriptive analytics. It's evolved to, what are the root causes of readmissions, such as my readmission rate is 4%. We didn't pay for that, by the way, and CMS doesn't pay for that. We didn't pay for it on the commercial side either. So the readmissions are coming from diabetes and heart failure. And then the next step is, given my population, knowing that I have so many members with diabetes and heart failure, what is going to happen this next year? I didn't have this when I was managing my population of who is going to be sick this next year. This now can be predicted. And then we're now cutting edge at a point of what do I do about this population with diabetes and heart failure? Who needs care? Who is at risk? How can I impact that next slide? So the sophistication of the analytics is such that we know where to push, we know who to interact with, and the data will show how to push in that area. In other words, do we do an outreach, do we do a member education, etc. So now we're going to talk about high-cost surgeries, and this is one segment of the healthcare spend pie, and this focuses on the surgical inpatient. We have other analytics that would address medical inpatient, OB, high-risk maternity, ED, outpatient surgery, injectables, imaging, etc. But we're going to focus on this. And preference-sensitive conditions are those which there's no definitive clinical guidelines, and multiple treatment options exist. And the example we're using today is total joint repair. Does the patient really need the surgery? Their knee hurts, the x-ray is abnormal. Are they going to be benefited by the surgery? And that is a question. And a couple of examples of this are high-tech imaging, preference sensitive. Patient has abdominal pain, let's get a CT of the abdomen. Or patient has a headache, let's get the MRI and MRA of the brain. And it's been shown, this is a zero-sum game as far as the dollars involved, but this increase in high-tech imaging utilization, which has gone up substantially, has not improved population health. Another example is ED visits. This is where the patient chooses to go to the ED. Half of visits to the ED could have been seen in the physician's office. Matter of fact, I did this myself for some years, seeing these patients. And the tragedy is the cost of the ED is in the $800 to $1,000 range, and the cost of seeing these patients in urgent care or an office setting is just a fraction of that. Now, with the high-cost surgeries, you have to take a look at there's going to be more sore joints because of the obesity, and because of the more chronic conditions, there's going to be greater need for pre-op decision making. If a patient comes and they have bone on bone and a sore knee, and they're 78 years old, is it a good thing to operate? Well, yes and no. What if they're a smoker? What if they have heart failure? What if they have diabetes? And what if they had a heart attack 1 year ago? So there are other therapies that can be done, and this is a literature example, just came out a month ago, and what was done was to take a look at patients who have an indication for total joint replacement, and they did a randomized controlled study, and that kind of a study is the gold standard for a medical intervention. And they had two groups. One, they operated; the other, they used medical therapy, and that was exercise advice, insoles, pain medication, and they found in the medical group that only a quarter of the patients underwent total knee repair at the 1 year point. And so what that says is, if you have a patient that has multiple medical problems, they're older, then there can be a good outcome with medical therapy, and you can avoid the surgery with its attendant risks. So they found also in this paper that the total knee replacement had more serious adverse events. Most patients, like I said, did not go on to surgery. They did find that patients who went to surgery had less pain. So it becomes a choice, and this choice should be given to the patient. Orthopedist that I had associated with my health plan was telling me about his situation with this, and he said, Kevin, when I get a patient that I'm referred for a total joint repair, I take a look at their medical therapy, and usually it's not maximum, so I maximize the medical therapy, and then they're fine. I don't see them again, and I don't operate. Now, he was in a situation where it was pay for outcome, that he was not paid by the surgery. So there's an option now for medical therapy. Surgery is not the only option. Medical therapy can be considered for high-risk medical patients like I described, and medical therapy can be considered for non-optimally treated patients. Next slide. So what I'd like to do is now turn this over to Teresa, who's going to talk about what are the analytics involved to manage the preference-sensitive treatment, which is the main driver of surgical inpatient.
Thanks, Kevin. Hi, everybody. I'm T. Rukert, and the solution consultant with CO. And as Sean mentioned, I'm a nurse by background. I have a master's in case management, and I'm excited to be able to spend some time giving you an overview of our PST model and our health analytics solution. So our preference-sensitive treatment model, or the PST model, what it is, it's used, excuse me, to identify and predict who is at risk for having PST treatments in the next year. And we use medical claims, pharmacy claims, eligibility data. And what it does, it's designed to help us to optimize the effect of interventions to improve the health of patients. We do this by educating and encouraging patients to take part in their healthcare decisions, which can then help to reduce costs and reduce any unwarranted surgical decisions. And so I'd like to talk just a minute about preference-sensitive treatment and preference-sensitive conditions. And so preference-sensitive conditions, for those conditions, there's really more than one treatment option. There's no definitive clinical guidelines. And for preference-sensitive treatments, that's where there's care, where clinical evidence, it does not clearly support one treatment plan. The appropriate course of treatment will depend upon the patients and providers looking at what are the value and benefits and potential harm, and also the timing of various treatment options. So knowing what treatment phase a patient is in will allow us and help us to understand the options and if the treatment plan could change to a less costly or less risky alternative. The CO model looks at a number of different high-cost PST surgeries. So on the left-hand side are the current that are included in the model, and I'm going to talk a little bit about what's coming in the beginning of next year also. So on the right-hand side, you see the 4 that are listed to be looked at for future enhancement. I'm going to talk just briefly about the methodology before we get into more detail. And so what we're doing is, we look at the history and we look at the risk model, and we use that to calculate a couple things. We use that to calculate the risk of having surgery for these PST conditions and to calculate the episode costs. The PST model, it's a multivariate logistical regression model, again, that estimates the probability of a patient having surgery for that preference-sensitive condition. Indications for surgery in the next year are then regressed against it. So demographics, diagnosis, procedure codes, comorbidities, utilization, even socioeconomic status. And when we look at this, you look on the bottom and you see the timeline there. And so the baseline period is 12 months, and then we allow a claims lag period. And that claims lag period, so if someone had that surgery in that time period, we would know that, and that claims lag period does change depending upon the preference-sensitive condition. And then the prediction period, that 12-month period. A little bit about the model performance. So when we're talking about validating, number one, we use a standard validation methodology for predictive modeling, such as a split sample approach, for example, to develop the model, and that's our internal validation. And then second, we have a second validation on an ongoing basis. This is being used today. So this is utilized today and it's being used by our clients, and they give us feedback on parts of the validation process, and that is then incorporated into it. The thing that I want to talk to you about is the ROC, as it's called, or the receiver operating characteristic. And really what that's doing, it's looking at the accuracy of the model. It's looking at the relationship between true positives and false positives, those that we predict to have the procedure do and those that we predict and that did not. And so with the ROC model, an ROC of 70% is considered a good model, and all of our models are 70% or above. And so what we're looking at here on that graph, really what we're doing is we're comparing areas on that ROC curve. So again, we want to be up in that upper left-hand corner, and all of our models are up there at 70% or above. I talked a little bit about that there's actually 2 different models. There's the one that is there today and present today, and then the enhancement that's coming the beginning of next year. For that current model that's there today, just so you know, that's our first generation of predictive model for the PST conditions. We selected preference-sensitive conditions for that, predicted and identified the high-risk patients for having those surgeries in the next year, and that's been in place and implemented for over 4 years now. The types of clients we have, like large employer groups, consumer management companies or CMRs that service different types of organization, whether they be provider groups or help other organizations with decision support. So it's been implemented for 4 years with different clients, and then we are getting adjustments on those models, making those adjustments based on the feedback that we're getting from those current clients. If you move to the next slide, what you're going to see is the output, and we're going to initially talk about the current model, and then we'll talk about what's coming with the enhancement. So in the current model, looking at this table, this is the current output. And really the value here, it lets me know who is at high risk for this PST surgery so I can know my opportunities for intervention. So as we look at this, we've got our list of members on the far left-hand side. And what I look at on the far right-hand side is the ranking of my members. Looking at my ranking of my member to have that PST, and also I can see their last treatment and that actual PST score that is applied. Just kind of as a side note to let you know, in addition to the model, we do have different services available that our clients have used where we actually look at their programs both pre and post and help them to quantify the savings that were achieved by that. So that was just a brief look at the current model that's in place. I want to talk to you a little bit about the enhancement that's coming. And so when we look at the slide on the left-hand side, what you're seeing is the version 1, the current model. And remember, that gave us who was at high risk for this surgery currently. Coming the beginning of next year is the enhancement version. That's going to give us the remaining time opportunity, the window of opportunity to be able to have some savings in addition to who's at high risk for surgery. So with this preference-sensitive treatment model, the first one again gives us determine who's the likelihood, which members, which patients have a high likelihood of having this preference-sensitive treatment. Then the second phase that's coming lets us to assess the remaining time opportunity for interventions based upon the current treatment phase of that individual, where they are in the phase of treatment. And by combining that risk, who's at high risk, and the remaining opportunity for the individual, by doing that, then our model can determine the expected savings or create a composite score to rank the individual and identify the highest opportunity segment for savings. So I just put this next slide in because I just wanted to give you a visual of what I meant by the treatment severity or the phasing of those different treatments. So depending upon where someone is in that timeline, that window of opportunity, someone is at phase 2, well, there's less of an opportunity to do things before getting to that point of having that surgery than if somebody is at phase 1 or severity 1 having had those treatments. So again, lets us see that window of opportunity. What you're going to see on the next slide is the table that represents the output that's going to come with that enhancement that's coming in the beginning of the year. And so what this is going to do is that it is, again, going to let me see who's at high risk for having the surgery, but it's also going to give me additional information about that window of opportunity and the savings opportunity. So kind of near the left-hand side, what you see is the highest severity level, that first set of numbers over there. So it lets me know what one of those phases, like we just looked at, the person is currently in. And then as we move forward to the right-hand side, you'll look to see the remaining cost episode and expected savings median. The remaining episode costs are based on the timing or the phase. In other words, that the person is in and the possible savings of a person, in this instance, that was at that phase 2 level, if we look at that first patient, represents the cost. And then the median takes into account not only that information, but the risk that the member is having of having the surgery. So the risk that the member is having of having that surgery and the remaining episode costs, therefore letting us know the expected median savings that's available. So the remaining time opportunity that we have to achieve those savings before the surgery. Really what we're doing is we're showing the care manager the treatments that have been done, and the care manager that can consider alternate treatments using the information we provided to them based upon the patient's ranking and the expected savings and where they are at as far as the treatment phases. That was a high-level overview of the PST model. I also thought I'd take this opportunity to just give you a kind of broader look, talk a little bit more about CO Health Analytics. And so when we're talking about CO Health Analytics, I thought I'd just let you know, because I have a lot of folks ask us, where did the name CO come from? What is that? Well, CO means to know or to understand. And that feeds into our whole mission statement. Our mission statement really reflects what CO believes. And what that is that there is an urgency in driving positive change in healthcare now, and that knowledge is what enables us to make this change. And we do this by helping organizations think differently, by gaining knowledge through actionable insights to really solve these complicated problems, hopefully simply and efficiently. Focus, and when we look at the slide that's coming up, what you really see is that with these changes, there's a lot of different entities and organizations involved in population health and in taking care of individuals. And really, our focus is to provide actionable insights across this continuum to these different entities that are working with these patients and members. So by using prescriptive analytics as a focus to really foster collaboration across these entities or domains to drive positive outcomes and impact. Really what we're doing is we're sourcing data once and using it many times in the right format for these different entities to be able to then use that information and drive change. So for our solutions for CO's health analytic domains, we have 3 different domains that'll be up here. And really the solutions focus around those domains. On the left you see our population health analytics. And really, those analytics are intended to help identify where to focus. For things like, how I'm looking at my population, how do I identify the population to interact with? Who's at high risk? Besides who's at high risk, which of the members or patients can we actually have impact with? Where's our opportunities related to utilization and cost? How about quality compliance? Where are opportunities in regard to that? And once we've identified and taken some action, then being able to analyze our outcomes. What is the impact of our outcomes? What are the impacts of our incentives or our programs? On the left-hand and on the right-hand side, when we look at network performance analytics, we want to be able to understand your network, right? Be able to evaluate your groups, your providers, your costs, understand the opportunities within your network, so that we can then look at standardizing care across those top performers. And on the bottom domain has to do with stakeholder outreach. So if we use that information about who we identified for population health analytics, really to use that to drive appropriate outreach, the workflow, the communications, to efficiently utilize your resources to drive those desired outcomes. I'm going to highlight for you just an overview level the solution architecture. And so when we're talking about the architecture, we're talking about the platform and what I personally like to think of as kind of the backbone. And so if you look at the left-hand side, what you're seeing on those different circles listed there are the data and our data sources. And so we utilize or take in clinical, financial, and activity data, all those different types of data. And then that information is categorized in different types of definitions and applied to that population to create what we call a member profile. So all those different pieces of information are categorized and applied to each and every individual, each and every member or patient. That information then is what is used to then reproduce those reports, that data, those dashboards that we talked about in regard to those 3 domains in our analytics engine. So produce those things for population health. How do I identify folks? How do I evaluate the outcomes of our program? to produce those network performance analytics. How do we evaluate our providers and our networks, and where is our opportunities? And then utilize to also help drive the appropriate workflow and communication. The whole idea is to have data-driven behavior. And so the data comes in, again, applied to that member profile, and utilized for those analytics to drive that behavior. The right-hand side just represents the user interface. And really, it's a robust tool. And there's different areas, because what's important is to be able to get the right information to the right person so that it is easily utilized to help drive those changes. So the dashboards. The dashboards are that first level. Again, whether I'm an executive or a director of programs, I want to have the right information so I can make those data-driven decisions. Underneath that, you see our ad hoc reports. I think it's one of the real differentiators and benefits of the solution is its flexibility. Yes, they're those easy to access dashboards, but we cannot possibly anticipate every reporting need, analytic need of every single client. And so there's the ability to be able to do ad hoc reports in an easy way, and I'm a clinician, I am not an analyst, and I can work those ad hoc reports. So to be able to then have that flexibility to not only have things come with the tool, but the ability and flexibility then to be able to do those ad hoc reports based on my particular organization's needs. And then the other user interface are those special tools to be able to then do the workflow and alerts and outreach and communication. The next slide that we're looking at here really, to me, represents that. I think the point that this is a journey and there's different places that folks may be on it. I mean, really, as healthcare changes and moves towards and moves more towards value-based reimbursement, organizations are all undergoing change today. And those organizations themselves are at different points along this journey. So if we look at the slide from bottom to top, it's really meant to be a visual to represent that. We have solutions at all those different areas along that journey or change. So for example, on the bottom, we may have folks that are beginning this journey, and they're looking to see what's happened. They want to transform clinical and financial data into meaningful insight into their population and network. So they want to be able to identify and stratify their member or patient populations. They want to be able to measure network performance. Some organizations may be more at that middle level now. So they're beginning to say, okay, what will happen? And so they're looking for analysis to drive efficient and effective care using actionable insights. Determine, what are the actionable care gaps, and how do we design programs based upon the opportunities to really impact cost and quality? How do we track our outreach and our outcomes for stakeholder outreach, and how do we begin to steer our network and our network performance? And still other organizations have moved on, and they're up at that top level. And they're looking to say, what should happen? How do we optimize care and operations with recommended interventions? How do we understand which specific interventions will get us the desired behaviors? How do we better evaluate our network? And how do we look and evaluate our members? And even to the point of designing packages and programs. So really, I think the point is that CO has solutions to help you as you progressed along this journey. When we looked at the 3 domains in that circle, I call it my circle slide, when we looked at that, one of the areas that I talked about was the population health analytics. And so what I'm going to be showing you here is the population health analytics home screen. And I'm just pulling this home screen up because I want you to see that it contains those main areas that you would want to look at when you're looking at population health. For example, how do I identify and stratify my populations? Well, first I need to understand my population and disease trends, my conditions. I need to be able to look at who's at high risk and who has high impactability. And we're going to talk more about that in a minute because that's a really important piece. How do I look at my costs and utilization, whether I'm looking at those ED frequent utilizers or looking at my readmissions, and also looking at my quality metrics, my compliance, where are my gaps in care and opportunity. So that was a look of the home screen to give you just an overall feel of those main areas. And if we move forward to the next slide, And I know it's going to be kind of an eyesore, but my point is I want you to see that the population reporting really looks at those key areas that you want to be able to look at when you're doing an analysis on your population. And so when we look at those key areas on the top left, an example is an executive dashboard. Because as an executive of an organization, I want to be able to go in and quickly get a look at those key areas. How is my organization doing? What is our population? What does it look like? What types of conditions is my population having? And what are the costs associated with that? What's the risk level of my population? So that high-level overview. When we look at the right, it's just an example of another key area, and that is being able to identify who are my members, my patients that are at high risk for financial risk moving forward. And not just who's at high risk, but which ones can I have impactability with? On the bottom left, taking a look at understanding what diagnostic categories are driving my costs, whether that be for hospitalizations, as in this example, and what conditions are associated, or what's driving my ED. And on the right-hand side, that other key area we talked about, being able to look at, what are my quality measure gaps? What is the compliance level within my organization for those various quality metrics? I think one of the key pieces, and I kind of hinted at it a minute ago when I was looking at it, was risk and impactability. And I think everyone at this point probably knows, yes, it's very important for me to be able to utilize my resources appropriately, help me to understand what my patient population looks like and who's at high risk. And so on the left-hand side, it's traditional risk analysis, looking who's at high risk, who's at moderate risk, who's at low risk, where are my high costs. I think the value of CO's health analytics model is actually marrying impactability with that risk. And so we have the ability to be able to take it one step further to give you more information, and that is to help you prioritize which patients or members you can have the biggest impact on. And so when we look at the right, the top represents the red. Yes, those are my high cost members. But in addition to looking at risk, which members do I have the opportunity to have high impactability with? Which ones, if I work with and help close certain gaps in care, will then be able to have some impact? So really, it's designed to stratify your population and ID where you can have the biggest effect. It helps you prioritize. In the next screen, we're going to be looking at risk and impactability and tie costs with that opportunity. And so again, identifying and understanding who's at high risk for high future financial cost is important, but I think just as important and extremely meaningful is understanding which of those ones you can have impact with, because just because someone might be catastrophic and have the prediction for high risk for high cost in the future doesn't necessarily mean that you can have a high impact with them. And so as we look at this table, just letting you see on the red going horizontally across, we have low, mild, medium, and high. That's our impactability. And then going down on the left-hand side of the risk. And so in this example here, a little hard to see, but really it might be my mild or moderate risk that really I can have the highest impactability with. So being able to look at cost, risk, and impactability together is a very valuable resource. From that analysis, the ability to then be able to click down or drill down and say, wow, all right, I have that chance of having high impactability maybe with my medium risk folks. Who are they? And then being able to get that information to be able to identify who those members are. And not just who those members are. We can see on the far right-hand side their impactability score. But if we look right next to it in that first yellow square on the top of the screen, again, impactability is about who is it that has the opportunity for highest impact by closing gaps in care, and what is the output of that? Well, on the top, it lets me see not only their impactability score, but for example, for that first patient or member listed there, their probability of ED admission, and if we actually work with them and close their gaps in care, what does that drop to? That's a difference of 71% if we can work with that individual. And in being able to do that, we need to understand what types of work do we need to do with that individual. What is it that can allow us to have impact? And looking at that bottom example, that first member we see their risk score, their impactability score. It's pretty high. And then it actually lets us know which gaps we can work on to have that impact. And my example here has the reduction in ED, but it's also a reduction in inpatient admissions also. One of the next pieces that we look at, I just wanted to give you a little bit of a feel for it, is, and you can go ahead and move forward from there, Sean, is looking at the outcome dashboards, because we identify folks, we help to facilitate things with workflow, but want to be able to look at what is the impact of our program. So looking at outcome reports, and just wanted to put up a couple of examples for you to be able to see that. Being able to look at the difference in cost distribution. So a quarterly dashboard for quality outcomes, or for outcomes, is looking at my cost distribution for both those that we have participated in the programs that you've initiated and those that have not. So being able to look to see, are my costs going down for those that have participated? And being able to look at those costs associated with them. We not only have outcome reports that look at things quarterly, by the way, we also have annual outcome reports. And when we look at the annual outcome reports, we're not only going to look at what's happening with our participants that are participating in the program, but also looking at the non-participants in the program. And that's an important message I just want to make sure to get across, because anytime you're looking at a cohort or a group that you've worked with, you always want to compare them to something else. And I'll give you an example. Let's say you were working with a population and they're sick, and they maybe had a lot of high costs or had a lot of high utilization in the first year you're looking at them. Well, just naturally, I think it's a regression to the mean. The next year, their costs or utilization may go down. And so you really want to know, if you want to look to see the outcome of your actual intervention, your program, you can't just look at that group you've worked with. You need to be able to also look at those non-participants. And so the annual dashboards, when we're looking, for example, over here at the utilization summary, allows us to do that, to actually look at the difference from the baseline to the measurement period, not only for those that were in your program, but look at that compared to those non-participants and see and understand which part your program really had impact on, and to understand your outcomes. And that's an example there of a utilization outcome report, an annual report. And then on the bottom right, there's also an example of a clinical outcome report. So being able to look at the quality measures and to be able to look at your participants versus non-participants, and is our intervention having impact on those quality measures that we have listed there. And Sean, if you move forward, I think that was probably my high-level overview of our health analytics at the end. In the beginning, we looked at the PST model, and then again, I just wanted to give you that high-level overview of the CO Health Analytics Suite, of which the PST model is a component of. And Sean, I think I'll turn it back over to you to take any questions that anyone may have.
Great. Thank you so much, Tia and Dr. Keck, for presenting today. You're correct. We're now entering our question and answer portion of the webinar. We have about 5 minutes for folks to submit their questions. And as a reminder, to do so, just simply use the right side of your screen underneath the questions module and submit those here. They'll be sent in, and we'll read them aloud to Dr. Keck and T. So as we're starting to get a few questions sent in, I'll also say, one of the questions we always seem to get is are we going to send out the recording and slides? And I can answer that one, that yes, we have recorded today's presentation. As part of the follow-up email to the attendees, we will be including a link to the recording. Okay, and with that, we're having our first question come in, and I think this probably directed towards T and as part of the PST model, and questions around data refresh and how often do we have a recommendation on how often to refresh data in the PST model?
Sure, Sean, we do. We recommend monthly or quarterly refresh for the data for the PST model. Thanks.
Okay, easy enough. And we have another question here coming in. This is, I think, either T or Dr. Keck. It's around impactability, and if we can expand on what factors are used to form the impactability scoring. And for this, if we need to bring in expertise from our analyst team, we can certainly do that offline. But any thoughts, Dr. Keck or T, on what goes into those impactability scores?
Yeah, I'll answer it. That the impactability is an additional layer of data that tells the risk-taking organization, can this patient close their gaps in care? And an example would be a diabetic who has not had their blood work and did not refill their metformin, which is a diabetes drug. The impactability would be, does the patient have the economic means to get to the medication? Do they have transportation? Do they have other signs of medical illiteracy? So you can tell between your members which patients with gaps in care or with risk of needing health care, where your outreach program can make a difference and where your outreach program cannot make a difference.
Great. Thanks, Kevin. Another question here, and I think this is probably directed to Dr. Keck, and drawing from your experience, prior to SEAL, what are some other areas, spend areas, where you see analytics directing substantial impact?
Well, what would be very prominent would be medical inpatient. If you look at where the dollars go, surgical inpatient, medical inpatient are big areas, but medical inpatient is very impactable with analytics. Patients get into the hospital medically or high-risk maternity, that's another one, because of a chronic condition. And do they have heart failure? Do they have coronary disease? Do they have COPD? So knowing which of your members have these chronic conditions, how sick are they, where are their gaps in care, then there can be an outreach program which can use a smartphone, it can use a nurse, it can use a doula to impact that member so that they improve the quality of their own health and reduce their admits to ED and hospital. So medical inpatient is a huge area. High risk OB. Outpatient surgery is a segue from surgical inpatient. Also injectables, a big area of spend, and this needs to be looked at. There's a lot of injectables that are given without benefit in oncology, for example, and the analytics can help in all these areas.
Great, thank you. And by my clock, we are at the top of the hour. So I'd like to thank, again, Dr. Keck and T for joining us today, and also the audience for taking the time to view our presentation. I will say that if you'd like someone from SEAL to contact you about what you've seen today, please indicate that when we close out the webinar. You should have a pop-up of questions. So indicate that, and we'll make sure someone reaches out to you. Today's session was recorded again, and we'll be sending that as part of a follow-up. Also, if you have additional questions, maybe we didn't have time to get to today, or as you think about what you've seen, we'll include a link to how you can submit questions to that, and again, we'll make sure someone follows up with you directly. And with that, we've concluded today's conference. I'd like to thank everyone again for your participation, and have a wonderful rest of your day today. Thanks.